All right, thanks, Fletcher. So before I introduce the speaker and let the presentation run, I'd like to briefly go over the agenda and a couple of housekeeping items. So we'll have three amazing speakers again, Dr. Rahman, Dr. Rogers, and Dr. Liu. And every presentation will be 15 minutes back to back, and we'll kindly ask you to hold on to your questions and leave it to the end of the period or the second half. And during the talks, please mute your mic. And when it comes to Q&A, please raise your hand using the raise hand feature in Zoom, or you can write in the chat. We can type it. Sorry, we'll just ask it on behalf of you. And again, this session will be recorded, so welcome to put your camera off, and we'll be shared on YouTube after all. And we'll have some, right, sorry, yeah, that's something else. All right, so without further ado, let me introduce our first speaker of today. Dr. Arman Rahmim is the Professor of Radiology, Physics, and Biomedical Engineering at UBC. And he's also a distinguished scientist and Provincial Medical Imaging Physicist at BC Cancer. After earning his master and Ph.D. at UBC, he was then recruited by Johns Hopkins University, leading the high-resolution brain PET imaging physics program and pursuing research at the JHU Departments of Radiology and Electrical Engineering. In 2018, he returned to UBC and his lab, Qurit. Sorry if I pronounce the Qurit the lab name wrong. Focuses primarily on molecular imaging and therapy. Dr. Rahmim disseminates his knowledge in many different ways. He's authored a book, published over 300 papers, delivered over 180 invited lectures globally. Plus, he also runs a YouTube channel called The Molecular Imaging and Therapy, featuring not only research content, but also academic advice and more. So strongly recommend everyone to check it out when you have time. Beyond that, he has received many notable awards and held leadership roles in various communities, spearheading initiative in AI and dosimetry. So whenever you're ready, you can take it away.
Thank you very much. Let me share my screen here. Are you able to see my screen? All good?
Yep, you're good.
Okay, excellent. So thank you very much for having me. Let me try to time myself. So thank you. I appreciate everybody being here. Excited to be talking about this topic of trustworthy AI or moving towards trustworthy AI ecosystems, including emerging foundation models. So I want to start with a story. In 2020, where the AI tsunami was hitting medical imaging. So I'm a medical physicist. I do a lot of medical imaging. And specifically, I do nuclear medicine imaging. But for the purpose of this talk, really, it's broadly applicable to medical physicists involved in medical imaging. And so I was asked in the Society of Nuclear Medicine Molecular Imaging to chair a task force, to put together a task force to deal with this tsunami and to make recommendations and to understand how we are supposed to understand the opportunities and the threats actually provided by AI. So that's what we've been doing, and I was the chair for 4 years, and the chair continues to have a number of efforts. But this is a key sort of a cycle we arrived at. That we in medicine we start with the patient, and then we go to imaging, specifically in medical imaging, radiology, and there's a whole number of places where AI can enter the picture, whether it's in instrumentation, for example, where you acquire an image, whether it's in a CT scan, MRI, PET, what have you. You reconstruct the images. And by the way, medical physicists enter every single point here in this chain, actually. They can enter. Or they can heavily collaborate on these fronts. And then you have the post-reconstruction image enhancement. You've already reconstructed an image, but you could actually further improve it, maybe denoise it. And then you arrive at an image. And then from the image, you need to go back to the patient and the provider to make a decision for the patient. So you go from patient to image and then from image to patient. And then going backwards, also image analysis, AI has a big role and has put significant potential roles. Discovery tools to extract patterns in the image that maybe the human eye is not quite able to see. Diagnostic systems and reporting, and ultimately clinical decision support where certain recommendations might be made to clinicians about what to do. And again, physicists can enter the picture here. So this led also to two specific special issues. This is in general PET clinics. Again, it's very specific in the title to PET, but the paradigms were sort of spelled out here. There are a couple of key articles that came out. I want to encourage you to look at them. One is called A Brief History of AI, How to Prevent Another Winter, because we've had two winters so far in the world of AI, and now we're in the third summer, and the question is, are we going to hit another winter? And also the importance of objective task-based assessment. So I think what was raised here in these articles is the fact that in the world of AI, there's a lot of exaggerated claims, and that an image might look very pretty, but it may actually be worse or maybe at the same level as had you not applied AI at all in terms of the specific clinical task performance. So if the image looks pretty, that doesn't mean that it's actually good. So you know, let's see. So sorry, let me just go back. Yeah. So now and then there's on top of that, there's foundation models emerging, and it's hard to define what foundation models are, but there's like some overlap between all these different techniques, and often they involve very large multi-purpose training data sets. You're not just focusing on one kind of cancer. The idea is just as a human learns many different things and they cross-inform each other, we should have very diverse data sets. You need a large model size and computational resources, and this is a big limitation or a big thing to tackle. There's a lot of self-supervision going on so that you're looking at the data without even necessarily annotation, but learning patterns about the data. So you pull all this data together and you just look at these images and you do self-supervision or semi-supervision training. And then after that, you could focus on a specific task and you do downstream task optimization for very specific tasks. And so one of the paradigms that we've also developed in these discussions is the fact that when you're evaluating an AI algorithm, you need to evaluate it very methodically. Again, a pretty image doesn't mean that it's any good in reality. And so you could start with proof of concept evaluation. Let's say if you're doing segmentation, you could start with typical metrics like DICE scores, which are not clinically that meaningful. But then you move up, you look at maybe tumor volume assessment and whether these tumor volume, let's say you're trying to automate the process of segmenting tumors because clinicians don't segment tumors because it's too time consuming. And we know that if you're segmenting tumors and you're measuring the volume of tumors, that can be quite predictive of outcome for patients, and that might allow you to modify therapies. But nobody does it because it's too time consuming. And this is a great place where maybe a third of the research right now in image processing is about segmentation. And so ultimately, can I use those AI delineated tumor volumes like molecular tumor volume or whatever kind of tumor volume to better predict outcome for patients and ultimately assess also beyond deployment. So a YouTube channel was mentioned. This is a QR code to our YouTube channel. There's a number of videos there. Here's one I would recommend you look at, From Pretty to Useful AI in Medical Imaging. A good story about how AI can be deceptive and it may make pretty images. It may even make nice papers, but is it actually useful? So it's good to pay attention to these things. So one of our task forces, or one of the working groups within our task force started to talk about opportunities and challenges, how to move towards trustworthy AI. So what we talked about is that there's a need for concerted effort to promote the application of AI technology by engaging a wide range of entities while protecting our patients and society. So here's an example. Again, specifically, it might look like nuclear medicine, but it's broadly applicable to all kinds of medical imaging. You might have the healthcare providers, the patients, some kind of an AI solution, but really there's a whole array of entities that have to be thought about. Malpractice. What if you misdiagnose a patient and bad things happen? Who are you suing? Who's paying for the AI solutions? The AI industry. How do you interact with them? The storage systems, the patch, the imaging archive systems. How do these things interact with AI? So there needs to be a harmonizer in any successful endeavor. If you're in a university or in a community setting, if you want AI to deploy it in a trustworthy, meaningful way, you need a harmonizer that kind of brings all these things together. And the challenge of AI trustworthiness is the willingness of the physician and the patients to actually depend on a specific tool in a risky situation. And that's the measure of trustworthiness. And it's the trustworthiness of the AI system itself, the algorithm, for example, but also all the people and processes. You might have a perfectly good algorithm, but it may be misused or not used properly. So the entire AI ecosystem. So we identified, and just because I only have 15 minutes, I'm just referring you to publications. We identified 12 elements that make an AI solution in medical imaging and medical physics trustworthy. Things like human agency. The humans have to be ultimately at the center of it. Ultimately, humans are responsible. Safety, oversight, fairness. So we know that AI solutions can be, and so fairness is one, and also diversity and bias awareness. For example, we know AI solutions can be sexist and racist. If you don't have sufficient training, if you're only being training on a particular kind of data set, your AI solutions will be biased. There's a lot of evidence that they can make for different for minorities, they can actually do, or for the rare disease community, they can mess things up. So bringing all these together and being aware of all these things that create a trustworthy AI solution is very, very important. Now let's move to foundation models, which are again coming in at a very fast pace. You know, we've all heard of ChatGPT, etc. And these are examples of foundation models that now, of course, we're looking at medical imaging, and so you could have foundation models that, in the case of vision foundation models, you could have things that are very, very broad, but also things that are maybe perhaps more modality specific, whether it's CT, PET, MRI, etc. They could also be organ specific and even task specific. But the trend is ultimately to have a lot of different diseases, perhaps on a particular. So there's a lot of stuff happening here. You're, for example, on a particular modality, but you have many different cancers, many different even organs, and you do some downstream task optimization. There are things emerging out there now like MedSam, there's SAM2 coming from some of the big players, and here's another one from Microsoft, Biomed Parse, where in this example, everything everywhere all at once. It sounds exciting, but of course these have to be evaluated very carefully. So for example, in this one, we had they had 82 different object types. You could be prompting. These are both vision and language models that are talking to each other. You could be prompting stuff and saying, okay, find COVID-19 infected region. And perhaps it goes there and does it. And many different modalities and sort of the ability to do prompting. So there are a number of opportunities with vision and language models. I want to mention four of them. One of them is perhaps, okay, these are ideas, that you look at patient reports, large language models, no vision here, just language models, like ChatGPTs, but fine-tuned for radiology reports. And so you would be taking the reports with all the findings, the elaborate findings that the clinicians have. They also do impression, the ultimate impression that they get based on all these findings. Can we possibly use large language models to take all those findings and they themselves generate the impression? Can we use all the entirety of this report to extract classification of disease from the report? More than that, beyond just language models, can we use vision transformers to combine both text and images to do better classification of disease? And ultimately, can we also, I mentioned too, segmentation. Can we not just look at images, but look at reports to do a better segmentation? Because we take many things from the natural scenery world and we forget that medicine is much more complicated. In natural scenery world, like an image is not male or female. An image is an image. And you don't have too much text going on necessarily. You have an image, where's the cat? Whereas when you have a patient, there's a history of the patient. There's the sex of the patient. There's, the age of the patient. There's, smoking history or whatever. Why are we not using that? Because often we're just used to the natural scenery world and copying the solutions, perhaps expanding them, but we're not thinking that in medicine things are different. And I think we need to add some nuanced understanding of these things to the picture. So again, for these different four areas, there's people, for example, again, taking things like ChatGPT, but fine-tuning it on actual reports, providing those reports. So radio or Llama, for example, Llama 2, and then doing it for radiology and doing impression generation. There's this thing called Impression GPT, and I'm just providing examples of these kind of efforts that are out there. So again, you're doing impression generation. Here's another one specifically for my field in PET imaging and nuclear medicine PET reporting. And we even took these models, very important to evaluate these models because, people publish, but then it's much more important sometimes instead of creating yet another model to take an existing model and publish that model in your own data set and evaluate how well it works. And so in our case, this model was from a friend and colleague of ours, but we independently evaluated and performances were okay, like 3 to 3.4 performance out of 5 in how accurately the impressions were being generated. Classification is another one, right? So for example, you have these models. Can we measure the classification of lymphoma or lymphoid cancer? It's a particularly prevalent kind of cancer. And maybe 20% of PET scans are on lymphoma patients. Can we read the reports and actually predict what the Deauville score, which is this classification for lymphoma, is? So yeah, and can we also look at images? So this is an example by one of our colleagues where he's taking not just images, but also, sorry, not just text, but also images and bringing these things together. And based on these, automating the process of classifying disease. So the clinician makes the report, and based on the report and the images, you come up with the classification. And also segmentation. So you have these models that you can take text, not just images. Many people do just images, but images and text and the history and the background of the patient to do better segmentation. So I'm going to go back to this paper that we talked about, and I want to try to quickly wrap up. The idea is in here, we outline the fact that there's a lot of exaggerated claims that are happening there, many poorly designed studies, the black box problem, bias, many things that could risk application of AI. I want to refer you to an extremely good and thought-provoking document or YouTube video. I highly recommend people look at it. You might probably learn more about this AI from this video than from anything else you do, because it hits at the human level and trying to understand what does AI even mean. And you may want to listen to this late night when you're at a sort of not distracted from many things, just as you're falling asleep even, just listen to this. It's a very good video. But the idea is this person, Hubert Dreyfus, many years ago, when everybody was saying in the previous generations before their winters hit, were saying, oh yeah, AI is going to take over the world, and it didn't. It failed, and the winter hit. He was predicting based on the philosophies of deep thinkers like Martin Heidegger, the great thinker, that the AI back then, the symbolic logic AI, will fail, and it did. So now also there's a lot of exaggerated claims. We even have the renowned Geoffrey Hinton, something like 8 years ago, saying something like, I anticipate 5 years from now, there will radiologists. If I were a radiologist, I would get out of the way because AI is going to replace you. 8 years later, it has not replaced radiologists at all. What it has done is that less people are coming to radiology. They're spooked by the fact that AI is going to take over their jobs, but now we have shortage of radiologists because of these kind of exaggerated claims that people are making. And people target radiologists because you have this very beautiful data set and they're like, yeah, AI is going to take over. But it actually turns out, sorry, I'm going a bit fast. I want to make sure I wrap up in the next 2 minutes. It's just incredibly exaggerated claims. Like previously we were saying convolutional neural network AI was going to replace radiologists. Now we're saying foundation AI is going to replace humans altogether in everything we do. Okay, so these kind of exaggerated claims, and actually I was going to show you this. The mental demand on a radiologist is actually more than many other disciplines. And yet somehow radiology was targeted just because it has nice, clean data sets. And again, that was a misunderstanding. So I was attending a MICI conference in Vancouver a couple of years ago, and another founding father of modern AI shows up and just says, you know what, AI is going to replace all humans in any sense of intelligence. Like these exaggerated, sometimes ridiculous claims. So that kind of hit me hard. And I started to sort of brainstorm on my own thoughts and just my readings of great thinkers. And I wrote this philosophy of AI article. You may want to look at it. It's called AI Does Not Do a Single Thing Better Than Human Beings. And this may sound like a defensive position, but I don't think it is. Like I do AI, but many of my publications are in AI. I appreciate AI. But the idea is that AI arrives on the scene too late or just on time enough to perform a given task assigned to it. It's an extension of the human being. The human being opens up new paradigms and deploys AI to address the needs that it has. It's an extension of the human being. And in that very meeting, we had a good thinker, Rosalind Picker, who was saying a similar thing. Don't say, oh, AI is replacing human jobs. No, AI is a result of human creativity, and it is doing what the human beings are telling it to do, and it's doing a fantastic job in the tasks assigned to it. And I think that's an important difference. I just want to sort of end with this. Even in a game of chess, somebody might say, I'm being too defensive, but even in a game of chess, I say in that publication, even in something like game of chess, is an AI machine really outperforming human beings? It might be a misapprehension when we reduce a reality which we denote by a game of chess to an extremely narrow set of events. The moment a human being faces a chess playing machine in a series of moves and is ultimately defeated. How did the game come to me? How was the world in which this game took place created? Was the AI machine not an extension of another human being to defeat the opposing human being? Who created this very paradigm of meaning in which a machine defeats a human and defeated it? What is the act of winning? Is it a truth or is it a set of rules conceived by humans? What is the context or impact under which such a game comes to be? How are these many events and phenomena in connection to playing a game of chess created? Where do they come from, right? So just understanding these things more. I end by saying that at the end of the day, I love working on AI. It's a great tool that is emerging with exciting opportunities. We have to work hard to make it trustworthy. And a big part of that is not to make exaggerated claims or just to be satisfied with pretty pictures. And ultimately, at the center of it is human agency. The AI systems should empower physicians and patients, allowing them to make better informed decisions, fostering their autonomy. There needs to be autonomy. So let's work together. There's exciting developments. There's great tools for us to make a difference in healthcare, in medical physics, and more need than ever for collaborations, sharing of models and data, and robust, meaningful publications. So thank you very much.
Thank you so much for the amazing presentation, and we'll hold the question to the end. But let me introduce our second speaker of the day. So Dr. Jessica Rogers joined the Department of Physics and Astronomy at the University of Manitoba in 2022, after completing an NSERC postdoctoral fellowship in the School of Computing at Queen's University. With a strong foundation in engineering, holding a Ph.D. in Biomedical Engineering from Western University 2021, and a Bachelor of Science in Mathematics and Engineering from Queen's University 2014, her research is dedicated to developing clinically translatable tools for the medical physics community. Her work aims to enhance cancer treatment through computer-assisted interventions, including image guidance for gynecologic and prostate radiation therapy and navigation techniques for cancer surgeries. So whenever you're ready, the floor is yours.
Great. Thanks, Ham, for the great introduction. So I took a little bit more of a personal experience approach to my presentation today. And so I know there's already been a little bit of introduction, but just to give you a little bit of my own background, I did my bachelor's in the mathematics and engineering program at Queen's University in the systems and robotics option, and then carried on to do my PhD in biomedical engineering, which I completed at Western University in 2021. And I'll let you decide from those pictures there which one of us is really the scholar. I then boomeranged back to Queen's for my postdoc in the School of Computing. And really, what I want to note here is that none of my education was through physics programs. So despite having not been trained as a physicist, I landed my tenure track assistant professor position here at the University of Manitoba in the Department of Physics and Astronomy in 2022. And so I really just want to point out that it really is about your skill set and not the program on your degree. And medical physics is so interdisciplinary that there's a lot of different pathways to it. And I think that's going to continue to be the case as we incorporate more technologies, things like robotics and AI. So where my research really lies is in the space of image guide interventions. So I wanted to start today with a bit of context for that field for those who may not be familiar, and then tie this back to our AI applications that we're focusing on today. Essentially, image guide interventions are referring to medical procedures aided by images and computer systems that help our clinicians visualize, monitor, and target structures. And so while I'm not trained as a physicist, most of the tools and systems I develop and work with relate to sort of those two key pillars of medical physics, imaging and radiation therapy. Looking at the big picture, one way I broadly classify our image guidance technologies is into sort of four spaces. The first, and probably most apparent, is imaging, which can include a wide variety of modalities, and of course, is a very active area of AI medical physics research. The second is the software that's necessary for computer assistance. So this can include increasingly novel image processing, which provides a world of opportunity for radiotherapy delivery optimization, radiation simulation, dosimetry, and treatment verification. And so this is clearly a space where AI can shine and is really the focus of my own AI work. Next, we have tracking, which also includes sensing and monitoring technologies and can range from things like electromagnetic and optical tracking to biophysical or biochemical sensors. And finally, image guidance systems rely on our feedback mechanisms, which ensure that all these data types can be communicated back to the clinicians in intuitive and useful ways. So there's certainly potential for AI in both of these spaces as well, though perhaps in not as obvious ways as those first two spaces. But I will briefly highlight one application later in this talk. Finally, the vision sort of underlying my research program is in the creation of integrated image guidance and monitoring systems that are both clinically relevant and can be effectively translated into use by oncology, radiotherapy, and medical physics teams to enable high quality treatment, assess the quality of that treatment, and allow our clinical teams to acquire the necessary skills to provide high quality treatment in resource constrained settings. More specifically, the primary association I have with MedPhys is through my research in brachytherapy. For those who aren't familiar with this type of procedure, this is a type of internal conformal therapy where we use applicators or needles to place radiation sources directly inside or right next to tumors, allowing us to deliver high doses of radiation and preserve surrounding healthy tissues. And so my research in image-guided brachytherapy brings together those MedPhys principles of precision and safety and radiation planning and treatment quality, and I collaborate very closely with medical physicists to achieve those aims. I first want to highlight very briefly two applications of AI in my own research in the context of AI image segmentation, where again, segmentation is just the process of outlining regions of interest like organs or surgical tools, or classifying pixels as being part of that object or not. The first application I want to talk about is AI needle segmentation. And so I want to start with my first AI study that was published back in 2020. And while I still like this paper, it was an admittedly naive approach to AI image segmentation. And AI was just becoming a hot topic. And we really just wanted to see what it could do almost out of the box. I will also admit here that when AI first appeared on the scene at a lot of conferences around this time, I was pretty disenchanted with it and pretty resistant when my supervisor recommended looking into this kind of study. In general, I'm not a big fan of what I'll call throw it at the wall and see what sticks science, which most AI studies in the field were at the time. But reflecting now, I think maybe we needed that stage so we could really see where AI stood up and where it fell down. So perhaps the individual studies weren't all of high value, but the aggregate of them together is. So here you can see a 2D ultrasound or a set of 2D ultrasound frames from a gynecologic brachytherapy patient where we have multiple needles inserted. So you'll see those as those sort of bright white lines that appear. And we wanted to see how deep learning performed at segmenting those needles. We used the go-to convolutional neural network, or CNN, for image segmentation tasks, which was our unit architecture with a rectified linear unit activation function and optimization of weights via an atom optimizer with a dice coefficient loss function. And we want to test generalizability, though I'm going to focus on the performance on gynecologic brachytherapy here. But we used about 1,200 2D ultrasound images from a variety of interventional applications, all with needle-like tools like you see on the right here. With our training and testing split, we had 34 gynecologic images in training and 18 unseen gynecologic images reserved for testing. And what I really wanted to emphasize as a lesson here today is that we need to understand where the metrics that we use to evaluate our algorithms come from and that we're choosing appropriate metrics for our task. So here we have a representation of a ground truth needle in yellow, and we can overlay our algorithmic prediction in blue. We then have our false negative pixels missed by the algorithm, our false positive pixels misidentified by the algorithm, and our true negative pixels. So these are correctly identified as background by our algorithm. Because in needle segmentation tasks, that needle represents such a tiny, tiny fraction of the total pixels in the image, if we include metrics that take into account this true negative rate, those metrics are going to be extremely biased. So there's common metrics out there that we didn't include because they're not relevant specifically for this needle segmentation task. Finally, we have our true positives as well, which are correctly identified needle pixels. Probably the most common metric that you'll see for evaluating these is the dice similarity coefficient, which measures the overlap, but it really doesn't tell the whole story. So recall is useful for determining when regions are underpredicted or smaller than anticipated, and precision is useful for assessing overpredictions or regions larger than anticipated. So taken together, we start to get a somewhat more holistic view of our performance. So in this example image, we see a needle entering an error artifact and overlaying the ground truth and the prediction. We see we get some perturbation, but pretty good alignment. And I really don't want you to worry too much about the results of these studies here today. In this particular case, we saw good performance in DICE, recall, precision, and processing time for all of our gynecologic images. But the next kind of lesson that I want to take from this is that our algorithm didn't have anything included to guarantee needle-like segmentations or metrics. And so we had to add these sort of post-processing approaches to the end, which we used to remove these spurious regions. In general, we looked at two approaches. We looked at a largest island and a ransack approach, and that ransack performed a bit better. And so really, again, the lesson here is that sometimes AI can be complemented with traditional approaches, and it's okay to mix them to improve your performance. So again, here's just another example image here where we see a ground truth and then a prediction that doesn't really look needle-like. But we can implement that ransack approach here to give us a good final needle axis, and this enabled us to have very good positional and angular differences. So this particular study was the first general deep learning-based segmentation of needle-like tools in 2D ultrasound images and included multiple kinds of organs and procedures. And really the key takeaways here were that we could achieve accurate segmentation by only including a small number of application-specific images in training. And so this was promising for generalization. And this also gave us the potential for immediate feedback during interstitial gynecologic brachytherapy needle insertions. But of course, this was limited. There's sort of the classic limitations here of our small number of images in patients and some of our assumptions. The next study I just wanted to briefly highlight as well is an application for AI organ segmentation. And so this was a study that was done by my student, Marysia Shevchuk, and she was looking at automatically segmenting the urethra and the rectum in 3D ultrasound data sets from prostate brachytherapy patients. For that study, she used the KnowNew-UNet or the NNUNet, which is an open source segmentation algorithm that creates several UNet configurations, in particular a 2D, a 3D full resolution, and a 3D cascade configuration, and systematically determines the best configuration, which is then used to produce the final test predictions for comparison to those ground truth segmentations. Yet again, I don't want you to worry about the details of the results today, but looking at this DICE score for our urethra in blue and our rectum in green for each model, we can see that the 3D full resolution and 3D cascade models performed best overall with scores around 0.85 for both organs, whereas the 2D model, despite having a larger number of image slices available to it, had the lowest DICE score for that urethra because it doesn't capture the 3D spatial context, which again is important, especially in the case here where we have this small elongated structure. So in general, for our situation, we had that our 3D models produced better segmentations. Again, we need to look at multiple metrics so we can see for our precision and recall. The 2D model had fairly high precision for the urethra, which means that most of what it predicted as urethra was correct, but at the same time, it had the lowest recall. So this tells us that it missed a lot of the urethra that was actually there. And so if we had just looked at precision for this model, we may have drawn entirely different conclusions. Whereas if we looked at the urethra results for the 3D full res, in contrast, it showed better balance and therefore did a better job for finding the urethra. And if we also look at the rectum results here, both precision and recall are generally higher, more stable across all models, likely because the rectum is larger, more easily defined in the ultrasound images compared to the urethra. So even the particular organ characteristics are really important to consider when choosing both metrics and models. But again, in this case, in general, the 3D models performed better. One interesting behavior was not captured by any of the metrics that I've shown so far. And so Mauricio noticed that the model often predicted small fragments of the organ near the top and bottom slice of the scan, even after the ground truth had stopped. So here's an example for the rectum. And so as you move towards the edge of the image, the ground truth disappears, but the algorithm is continuing to predict. And so looking at it together, we see that in clinical practice, our physicians sometimes stop segmenting that organ when it's far enough away from the treatment region. And sometimes they do different things like including the fat layer or not. And so even if the organ is slightly visible, it could be deliberately left out or segmented differently in the ground truth. But the model is trained on the image and the segmentation. And so when it sees something that looks like the organ at the ends of the scan but isn't labeled in the ground truth, it becomes more uncertain, makes a lower confidence prediction like this. And so we see that if we look at boundary differences and consider cropping off the first few and the last few slices of our images where those differences occur, that gave us substantial improvements in performance for both our urethra and our rectum as well. And so the surface disagreement really just highlights the issue that we really need to communicate with our clinical teams to understand how they're segmenting these structures and understanding that different centers and individuals will have different standards and preferences, and we need to be able to generalize to these. The last application that I want to highlight really quickly is AI tissue classification. And so this was part of my postdoc work where we were looking at breast conserving surgery, where we're removing the tumor using an electrocautery tool, and then that specimen is sent to pathology where they analyze whether there's any remaining cancer or not. And in about 1 in 3 women, there is remaining cancer, and these patients have to have second procedures. And so my work in this project was focused on bringing computer assistance to the procedure, so creating an integrated system of imaging, sensing, and tracking methods. So we used biochemical sensing here using what's called the iKnife system. And this allowed us to determine what type of tissue the surgeon was cutting through at a moment in time. And so the technique is really interesting, but it didn't have spatial information attached to it. So we had to integrate other information here in terms of tracking and imaging as well. But again, this was all supported by deep learning pipelines that allowed us to really rapidly interpret this intraoperative data because we had multiple different data streams coming in with all different kinds of information. And we did do this actively at the Kingston Health Sciences Center, where here you can see that iKnife system in the back as well as our navigation screen. But again, this gave us an overwhelming amount of data. So we got imaging data, we got our chemical signal data, and all of that was bridged by this navigation system. And so we're still sort of actively investigating the best way of integrating all this information and portraying it to our clinicians. And deep learning has been really helpful along the way. And it's still something that we're very actively investigating as part of this project. And so again, this work was equipping our surgeons with different sensing and tracking technologies with all different forms, but really it was enabled by the fact that we could use deep learning at almost every step in the pipeline to automate and streamline things. So we could outline the tumor in the ultrasound images, or we could classify those chemical signals into the different tissue types. So just to finish off on a more general note, there's tons of progress happening, obviously, in AI and medical physics. There's a few very recent articles that are really highlighting some of the directions that we are going and we can go with this. So I really enjoyed this letter to the editor from the Journal of Applied Clinical Medical Physics. And also, I wanted to highlight this article in particular, this artificial intelligence in medical physics, which was entertaining in that they asked ChatGPT to write an article about where it thought AI was going for medical physics, and then analyzed that article that AI wrote about itself. So that's an interesting paper as well to take a look at. In general, I see sort of four main directions where things are showing up in MedPhys. One is the case of image reconstruction, where here I've just put examples of some papers that have come out in 2025 in these kinds of spaces. The next emerging direction I see is our segmentation and our contouring, particularly in the context of radiotherapy planning, which is really where my own work falls. And that ties in really closely with dosimetry and radiotherapy planning as well. And then the final area where I really see this cropping up is in the space of quality assurance as well, which is a really key part of medical physics, where patient safety is really the ultimate goal that we need to reach. And so we have sort of these main areas that I see, and really all of these are effectively decision-making tools. So they're equipping our clinicians with tools to make better decisions about the patient's care pipeline. And this applies both in that MedPhys context and in the image-guided intervention world where I come from, where we're seeing AI being used for real-time tool tracking, anomaly detection, enhancing our images, computer vision, all of those same kinds of problems where we really require accuracy, speed, and patient safety to be prioritized. The last thing that I wanted to touch on were sort of some of our key challenges, which I think Arman covered quite comprehensively. So I'm not going to cover in much more detail here, but I think really the most important one here is that we need education. We need our clinicians to know how to appropriately use the tools, interpret the results, decide what scenarios they're applicable under, and putting that together with trust. And really what that boils down to is the need for collaboration. We need to include humans in developing these things. We need to talk back and forth between our development and our clinical teams. And ultimately, these are decision assisting tools. They're helping our clinicians make decisions. They're not making decisions on behalf of our clinicians. And then, of course, there's always challenges with our data sets in terms of quality, diversity, and size to enable generalization, and challenges in workflow and regulatory aspects as well. So I'm just going to finish off with a quote from Eric Topol, who is a cardiologist and vice president at Scripps Research. And I think it's really easy for us to sometimes forget the human aspects of this AI research. And so I really like this quote from him where he said, "What I'm most excited about is using the future to bring back the past, to restore the care in healthcare." And so his view is that AI is going to give the gift of time to clinicians. It's going to give patients empowerment if they want it. And so it's going to allow there to be more connection between the clinicians and the patients in their day-to-day interactions. So I'll end off there, and thank you.
Thank you, Dr. Rogers, for another great presentation. So we'll now move on to our third and final speaker of the day. Dr. Chang Liu is a computer scientist with expertise in image processing, computer vision, and computer graphics. After earning his Ph.D. in computer science in 2011, he joined Henry Ford Hospital as a researcher, where he spent over 7 years collaborating with oncologists and medical physicists to enhance radiation therapy through advancement in medical imaging, segmentation, and registration. Recognizing transformative potential of big data and artificial intelligence, Dr. Liu joined Radformation Inc. in 2019, striving to drive impactful changes in the field and hoping to bring more benefit to a broader community. Whenever you're ready, you can take it away.
Right. Can you hear me? Cool. Thanks for the introduction. So as you have heard that I don't have a medical degree nor a physics degree. I'm actually a computer scientist. I have a computer science degree. And in fact, I was not majoring in computer science for my bachelor's. I'll tell you why at the end of the talk. But let's start my talk. I'm gonna briefly tell you my story, where how I came to where I am, and what I think I will be in the future. So a little bit details about me. I started my PhD in computer science at Wayne State University, Detroit, from 2005. And I did several projects during the 6 years journey. These are some three of them. So the first project I did was with this handwritten digital recognition using neural networks. Yeah, neural networks. The same neural network as uh, like modern AI is using, but more or less they're different because that was less powerful. And I could still remember how slow the training was. And we only have very scarce of data to train, and the results were not so good. So, for publication's sake, I did that, and it introduced me to AI, at least. So they have to find something to work on, right? And even my PhD advisor had to find something to work on because he was lacking funding from SF. So he had to get funding from NIH instead. That's why I came to know these medical imaging applications. Now he was introducing. So this was my second project, was to visualize a cortical system using computer graphics. So you will see in this, I'm using surface rendering to render tumor and the cortical surface and like the feeding vessel. I'm using like volume rendering to render these microhemorrhages that happens introduced by the tumor. So part of the project was to trace the progress of the tumor along the treatment, a long time. So there's some shape analysis of the tumor going on. I did. So that's why I came to the third project. This is we call the shape retrieval project. That means if a shape is represented by a mesh, then how do you come up with a simplified signature of this 3D shape so that you can use them as keys to find similar shapes. These are interesting projects, right? And I mean, they're totally fine to get a PhD with all these. But then what's next? Like, I'm actually very lucky to know a lot of good friends during my PhD study, and that's part of the meaning of education to me, to know good people. So I have a good friend. He was actually really good, and he was in this medical physics department. Like he graduated earlier than me, and he got a position in the medical physics department in radiation oncology. And he introduced me to the field of medical physics. So at the time, I was even not aware the difference of between radiology and radiation oncology. So when I wrote something on my resume, I sometimes wrote radiology, sometimes wrote radiation oncology. Wow. But after the 7 years experience in Hereford Hospital, and I think I'm quite familiar with the difference now. So keep calm. Okay. So from 2012, my first job was a clinical software engineer. Then I was promoted to like a senior scientist at the very end of my career. But at the beginning, I was just developing, was assigned task of developing software for medical physicists, right? So anyone know the Winston Last tests and film QA? So if you're a medical physics major, you're probably familiar with these. So I'm trying to write these programs to help them to analyze the images that they acquired during the film QA and the Winston Last, because I have this visualization skills and the programming skills. So that was interesting. Like one thing shocked me that was how lacking software was in the department. So people are just doing a lot of manual stuff before I joined. So they told me that they were so lucky to have me there. And I would say, oh yeah, because you're doing everything manually, like even the field QA. And there was an interesting story. Once a senior physicist came to me, and she was very senior, and she told me that there's probably a bug in your program, in this film QA program. Because I see that your passing rate, the gamma passing rate is 98%, but looking at the visualization you give me, this is a heat map, right? You're looking at the visualization, the red is now passing point, and all the others are passing. So by looking at these points, I don't think it's 90. I don't think it's 98. I think it's less than that, because you see how big these red spots are. So eventually, I had to use my backdoor program to zoom in the image and count the number of red pixels and give her the formula, and eventually came to the agreement that yeah, the program has nothing wrong. It's just how we perceive the image is wrong. So that showed me that how this visualization human how critical that for us to help people to understand the results, right? It's just not giving them the answer, and the visualization and the interaction between a human and the computer is actually very important. So moving along, I actually joined this bigger project from a research grant to do this adaptive radiotherapy. It was like a high school sex. So everybody was talking about it. Everybody was talking about it, but nobody was really doing it. So we're doing it actually, and we developed this software to use deformable illustration to align images and to accumulate those. So in the end, we know how much dose we got during the treatment course. So there are a lot of interesting work I did on image registration and quantification of the arrows and those accumulation, those transfer. So soon after that, I came to the year of 2006, and when AI was booming, modern AI was booming. I moved on to this AI segmentation project. Actually, this is my first real AI project I found interesting because it's really working, right? Compared to the handwritten digits, it's really working. Right. So we were interested to discover how well it does. So this project, we actually have the luxury of having different people to provide the reference contours. So we're trying to see if statistically the AI-generated contours is different from human contours. So basically, we did this by averaging all the contours that generate a consensus contour and comparing each individual contour to this consensus contour to see if the difference is noticeable or not. And eventually, we're happy to find that the AI-generated contour is even not differentiable from human contours. So which means you can treat it as an independent party who contoured on the same image. That's very exciting. So around 2019, actually, in that time, if I remember correctly, a lot of renowned scientists moved from academic positions to the big companies like Google, Facebook. You can name a few, like Fei, like some of the four big guys, right? They moved to these companies. So I was thinking like, why that is, right? Because I think the paradigm of AI has shifted in those years because it's big company has resources. I mean, to not only to train models, but they have big data and a lot of talents there. So I decided to maybe it's a time for me to move, and actually, Radformation gave me the opportunity. So that's why I moved to Radformation. I think I can use my skills and my discoveries to help more clinics besides Hereford. So I moved to Radformation in 2019, and I started this auto contouring product for Radformation. So probably you are familiar with auto contouring, like using AI. So here's the basic idea is basically you have an image and you want to know the mask the region where the prostate is, right? And so your input is the image patch and output is a binary mask indicating where the structure is. In this case, it's a prostate. And the model is the neural network. So that was what I was doing since then. But then what? What do we do in the future? Like, we have already successfully applied this technique to over 200 structures and for CT segmentation, and as well as more than 50 structures on MR images. They're doing pretty good, right? They're doing pretty good. But still, we're interested to push forward because we're not just doing segmentation. We want to help the clinicians to solve their problems, right? So in the end, we identified a few problems that we want to solve based on user feedback and our own discoveries. So here's an interesting example. So this is a CT image, and we're trying to segment the liver. And on the left-hand side, you see the red is the human contour, which is red. And then on the right-hand side, the green is AI contour. And if you look at where the arrow points to, there's a gap between slices. Right? There's a small notch you see there. And if you look at this axial plane, why there is a notch? It's because there's some discontinuity between the adjacent slices. Why that is? Because consider how a physician contours the liver. He would contour the arm a 2D slice, like slice by slice, top-down panel. However, there's some inductive bias in our modeling because we use a 3D model. The 3D model has an inductive bias that it tries to smooth out adjacent slices. So if you use a 3D filter, it has intrinsically that bias. And in the end, you see a nice, like smooth shape in 3D, but it may not be what people like to see. So if you look at here, that the previous slides might not have this gap, right, in the center, but this slide has it. So there's a big jump between this. And we realized that instead of using 3D models, we better use 2D models just to mimic what a human contour will do. So in fact, that actually give us better scoring, even though the dice looks very similar. But if you send to a reviewer, human reviewer, he or she will find that the 2D model works better than 3D. And this is in contrary to most publications. If you look at the, if you do a survey, most people will say that 3D models make more sense because it uses more information of the image and it's better. Supposed to be better, but it's not helping people in the clinic. So that's where we're saying that domain knowledge actually is very important, and you have to focus on the task and help people to solve their real problems instead of thinking where the problem is. So again, we're also trying to move forward this adaptive radiotherapy a bit by improving the synthetic CT generation and dose accumulation, right, using deformable illustration. There's some interest from our customers who use the CBCT, want to use CBCT to do the ART. And there are a lot of issues, as I have mentioned, that the limited field of view of the cone beam CT and bad image quality and change of mass. Like change of mass is notorious difficult because you don't know how you should deform the image, whether the deformation makes sense, because some mass may disappear, or some mass may be generated during the process. There's no correspondence between two images in that area. So, like with AI, actually, we can have better guesses by using prior knowledge that AI learns. So this is another interesting topic. And thirdly, I want to show this how this domain knowledge helps in dose prediction. So by dose prediction, this is a work from my colleague. They want to predict the dose from your input image. So it's, at first glance, you will find it's very similar to auto contouring because the input is just a volume, a patch, or image, a 3D image. The output is another image, and in our country, it's a binary mask, but here it's a dose map. However, the intrinsic physics is quite different according to my colleagues' study. So they have modeled this input not as a 3D volume, but as a sequence of slices. Because they think that the beam, they model this input as a sequence of slices along the direction of the beam. So that way they can use a lot of the physics to model the interdependencies between these slices instead of treating every slice the same way. So in the end, they found that the accuracy is much improved. So it shows that if you know the intrinsic physics of a certain process, you can build better models out of it. So I will try to conclude. So there are other challenges and opportunities in the future, like how do we work with AI, like especially with AI agents? If you treat the AI agent as an individual, as a third party, right, it can make mistakes and it can have uncertainties. And as previous speakers already pointed out, and how we detect where the error most likely to happen and help people to identify them, and where the model is not sure about is what we call the uncertainty. And you may think these are the same, but actually they're not. There are publications showing that they don't coincide with each other. Just like humans, we make mistakes and we have certain things we're not certain of, but they are not necessarily the same things. So to better understand this will help us to work better with AI agents. And I do believe that human in the loop is a must. So we need to have, that indicates that we need to have appropriate user interfaces, like the visualization tools and software to allow users to give feedbacks and to analyze them on the fly. So these foundation models building is critical, as previous speakers already pointed out. And I want to emphasize this. How many of you read this beta lesson from Rick Sutton? I think this is a nice, short article. You can finish it in probably a few minutes if you're a quick reader. But I want to point out a few points from the article. First is we want to in general, build general methods instead of task-specific methods for AI. For example, like the transformers, right? That they can generalize to text processing or image processing. And by tokenize everything, you could put all things in the same framework. And neural network is another example, like by the law of approximation, like a neural network can represent any function at any arbitrary precision. So we should think about general methods. And one example is this physical informed neural networks. It's becoming hot, and especially you have a physics background, and there's a good opportunity that you can build something around it and find the new models that are generalizable. And also, the article says that it is essential to these methods that they can find good approximations, but the search for them should be by our methods, not by us. What does this mean, right? I'm giving an example of this GPT red plan. Actually, it's another work from my colleague, and it's actually a plug-in for automatic treatment planning Eclipse treatment planning system. What it does, it actually uses the same logic that a dosimetrist will use to generate plans. So basically, they are feeding the model with like different views of the image and the DVH, the image of the DVH. And basically, the model will try to read this image and try to find out the best plan based on the inputs, just like humans, right? So this is purely it's a purely it's a purely a simulation of the normal clinical workflow. But at some point, we need to think out of the box. Will we get a better plan by not by using other information or using the information in a different way instead of just try to mimic what a human does, right? So this is uh, but we're intrinsically convinced that we're doing certain jobs good enough. So we want to teach the machine for them to do it in the same ways. And that's not probably the best approach. We should let the machine, the AI algorithm, search for the best solution themselves by using the generalized methods. So, all right, I'm gonna close up with a few slices. So this is the AI Ascent 2025. I don't know if you watched this keynote, and there is a good conclusion and a good message I get from the talk. So where's the opportunity for AI in 2025, right? And you may think about, yeah, we should go and build the models. Yeah, there are a lot of good things we can do. But actually, this event is held by Sequoia Capital. So their conclusion is the value is in the application layer. So the value is in the application layer. The value is in the application layer. All right. What does this mean? It doesn't mean that you shouldn't explore any model and shouldn't train any models yourself. It just means that, well, now it's time for us to provide the solutions rather than models. So keep your users in the center, keep humans in the center, keep customers in the center, and try to help them solve problems, like I just said. And so now I'd like to close by citing Andrew Ng's words. AI is the new electricity. So now I'm gonna tell you why I'm actually having I was actually majored in electrical engineering for my bachelor's. Okay, so I moved on to computer science. Not because electrical engineering is easy. I learned motor. I learned the electrical generation, right? All these stuff. They're pretty hard, and that's the main reason I switched. You know, but how many people are still worried about? We should still worry about these problems because they're hard. They're still hard. Lots of hard problems. But the majority of us don't worry about them anymore. We only worry about how we use electricity to make things happen. So it's the same as AI, right? You could you're good enough. You could worry about building models, but I think it's time and start is already starting for us to use AIs to make cool things and help others to solve their problems. And the future is in your hands. Thank you.
Thank you so much for three of the speakers and everyone's presentation. So the now floor is open for questions if you have any, to specific or general to all three speakers. You can either raise your hand or you can put it in the chat.
So I think in the meantime, if nobody has any pressing questions, I can ask something to the entire panel because I think like all super duper great talks, like very, very educational, and really I think it's a good highlight of what we need to be aware of in general for all of AI. So one of the things that we kind of brought up quite a few times was that these tools are meant to be tools. They're meant to be used by humans and meant to support them and help them, not replace them. And I was just wondering, like there was words like quality and what is good quality, support and trustworthiness and all that sort of thing. So I was just wondering in each of your kind of clinical kind of aspects or applications, what would you say is one thing that you have to keep in mind the most, whether it be like communicating with the doctors that you're trying to actually make these tools for, the physicists that you're trying to help? What would be the greatest kind of quality that you are trying to improve by implementing these models?
So I can take a shot at this. I think there's a couple of key areas that we're exploring in our group. One is there's a whole field called implementation science, or sometimes known as knowledge. In Canada, we usually call it knowledge translation or even integrated knowledge translation, IKT. And it's a very, very important area where, and we recently had a video about this on our channel too. The idea is that for years, for example, clinicians had called, and this field of evidence-based medicine actually started in Canada, and um, people were saying clinicians should be practicing things based on evidence, not based on things that might be outdated, etc. But then soon they realized that when you practice evidence-based medicine, many times you even know something is the right way to do it, but you don't use it. It's like knowing something and actually wanting to use it. There are two different things. And so then that led to implementation science, which says, what should we do to get people to generate the right evidence and also to use that evidence routinely? So I think it's very important to have this in mind that we really need this field of implementation science to take the AI solutions that we're developing, as physicists, as engineers, and first of all, make sure that we're generating the right evidence by engaging very early on with clinicians, with users, that the kind of evidence that they want to see, not the kind of evidence in my mind. So we've done, and many have done so much work in AI, but only a minute fraction of that ever gets used routinely. Part of it is because the kind of evidence we generate has nothing to do with what clinicians, healthcare providers care about. Another part is that even if it has something to do with them, because they weren't engaged from the beginning, and there's all these other incentives and all these impediments that we never thought existed, that we need to understand it. So it's just not about, so there's a number of barriers to use. There's a great paper about this. I'll send it in the chat shortly. What are some of the key barriers to implementation of AI in healthcare? So I would say that's one important thing. The other sort of theme that I think is very important is so-called human in the loop AI, or more specifically, physician in the loop AI. And so the idea is that as you're developing AI solutions, when they're deployed by humans, that itself is a way to quality assess and to see how these things are performing. But there should be ways for clinicians not just to say, this is good, this sucks. No, for them to be able to refine those. So we need platforms to allow us to take what AI does routinely. Let's say, again, you want to routinely generate contours, as Dr. Liu was mentioning, or you want to create some kind of segmentations or whatever. If we're deploying this routinely, somebody has to quality assure these things, and they should have a way to modify them. And in the spirit of so-called interactive learning in AI, when they modify those things, not only is that quality assessment, that refinement should be fed later to the AI systems to interactively, they learn to do a better job. So the AI kind of learns from the humans and gives the respect to the experts that it deserves. So those two things I would say are important.
Yeah, awesome. I don't know if anyone else has anything else they want to add to that.
I can add a couple of comments, not much. I think, you covered it great there, Arman. I do really think that ultimately the most critical thing is that communication, having clinician buy-in and having that feedback loop with them of what they actually want. I do think that's the number one thing. But I think sort of dovetailing with that, I sort of mentioned it at the end of my talk there, but I think the other piece that is really critical is both education and exposure. I think, knowing what tools can't and can't do, and how to appropriately use tools is really important. And then exposure in terms of, I think, again, there's a lot of this rhetoric around of like AI is going to take over or whatever it is. And so I think just, having clinicians actually use the tool, see what it can do and can't do is better. Because I think, again, there's these fears they're going to take over their job or they can do this crazy thing that they really don't have the power to do. And so really letting them, again, education, learn the limits and the benefits of having those tools at their disposal.
Yeah, I want to say that like AI is actually good at br- making the communication better. Actually, it brings the technology to humans closer than ever before, like ChatGPT and all these things compared to using Google. And I do think that using AI gives us opportunity like to improve the communication, like between groups, entities, between humans or between human and machines. So there's yeah.
Oh, we got a question.
Hi, yeah, I'd like to ask a question. I think sometimes in medical physics, it's not uncommon for people to be users of AI, but not necessarily like developers of AI. And I'm wondering how important you think it is for us as medical physics to be able to like have some explicability of the AI, like the result it outputted, the decision it made. How important is that for us to understand why it did that, or is the result's accuracy enough?
So I can take a shot at this. I think that's a fantastic question. Recently, we had a debate that we organized in our society about explainable AI, is it necessary or not? And people were taking different sides to this. I think that there was a kind of an interesting realization we had also looking at some of the evidence. For developing AI versus evaluating AI, those are two different things. So you're alluding to that. So if you're a user, that's quite different than if you're a developer. For developing AI, our conclusion was that explainability is very important because that gives you insights and you could sort of use those insights to develop things further. For evaluating, however, even though some people argue it's useful, and I don't disagree with that because sometimes there's been evidence that something people try to look at, why is it that it's finding something to be a certain disease, and they realize the AI is looking at the caption of the image, in which hospital the image was acquired, as opposed to looking at the image, etc. So I would argue maybe that should be really done by the developers, not by the users. But there is some evidence that physicians, at least, when they are told this AI algorithm is explainable, they kind of relax a little bit too much, and they lower their evaluation standards. Like, oh, it's explainable, it must be good. But I think so. So we have to be very careful that if something is explainable, that doesn't actually mean it's good. So I think there is a bit of a disagreement about this, but I would say for development, definitely, I've concluded it's a good thing. For validation, I'm personally okay with AI not being explainable, just like a human is not explainable. Like you don't know what's going on in this person's brain, but you kind of trust them after having carefully evaluated them. So I'll stop there.
Yeah, I would agree with that. I would say, like, I think just a basic general knowledge is advantageous, but the reality is, I mean, through your courses, your education, you know somewhat the premise of what tools you're currently working with are based on. So, your LINAC, you know generally how a LINAC works. Do you know the nitty-gritty of that design, or do you just trust and then quality assure? I think our algorithms are in the same kind of box that, yes, I agree that explainability is really important for development, but I think having a general understanding of the underlying principles is sufficient as a user in most cases.
Yeah, I totally agree. So that raises this error detection and this uncertainty detection problem. As we want to know where the errors could happen in our evaluation and where it's uncertain. But in theory, like there's probably no proof. But in theory, I think in practice, I think usually there's a tension between explainability and the usability of the model. The more you can explain, the less useful. In practice, I think it's like that. Right.
Yeah, that's a great point. You mentioned uncertainty. I would add that perhaps unrelated to the question, but I think it's very important for increasingly for AI systems and algorithms to report how certain they are about the decision that the algorithm's making. Because sometimes you could have an algorithm calling something cancer where it's only 51% sure. And so I think sometimes you could argue it's better not to even call it. Or if you're calling it, to really report that you're very uncertain about your assessment of things. So I think it's very important if AI systems are going to be incorporated and trusted for them to report how certain they are about that assessment.
Great. Thanks. Well, since we're also waiting for our other question, I do have one quick one to ask. That was actually brought by Dr. Rahmim presentation, but it's general to everyone in terms of data accessibility, in terms of like race, sex, and gender across countries, privacy, and everything. Like, what do you think the solution for that would be? Like, in terms of accessing data from a broader population, but we're limited by like the country boundary, kind of.
It's a very unless Jessica or Chang, they want to say something. I would say this is a huge problem right now. One reason why deep learning has truly taken off, you could say that whole revolution, deep learning revolution, happened because of three things. One was the algorithms that were designed years before that, though, but then there was the computational power, but then there's data and these kind of competitions that are put out there with hundreds of thousands of millions of data. Whereas in medical imaging, we might have the algorithms, maybe. The computational power, we have certainly issues, but data very limited, limited by ethics. That whole debate, who owns the data? Like who's the owner of it? Does the patient own the data? Who owns the data? And so that whole debate, or ethical debate. But I think imagine what we could do if data was widely available. And so that's why some people believe, the AI, we're just at the beginning of the AI revolution in medical imaging, just because we have so few data in every single effort that we've done, or most efforts that we've done. And that's a very, very tough problem, data sharing. There's issues of course, ego and all these things that are happening. I would say I was at a meeting and somebody said, we should go back to our roots in physics, in particle physicists. When they write a paper, there's like thousands of people on it because in CERN and in all these places, physicists, hundreds and thousands work together. Why can't we do a similar thing in foundation and AI models for medical imaging?
Yeah, I'm not sure I have much to add here. To be honest, most of my work is in very niche applications, and so there just isn't big data sets available. And so most of the people who I need on board it's a small enough community that they are on board. Um, but I can say that every conference, every venue I go to, this is a topic that comes up, and it's definitely a major stressor in the community. I don't think anybody has the answer at this point.
Mm.
This is a little bit off topic, but I just kind of want to throw this out here. I don't know how many people have read The Immortal Life of Henrietta Lacks, but I highly recommend it if you haven't. But it deals with patient ownership of tissue and cells.
Mm.
And there's some context in there as well of legal implications in that context. And I think we're reaching a similar point with patient data, again, of ownership, but now we're talking digital information. So I think there's some really interesting parallels. And I don't think that issue has been particularly resolved in the last 75 years. So I think we have a difficult path and lots of sorting still to be done.
What I'm seeing is that ethics boards. Sometimes some of these things are self-imposed too because we've heard so many no's. But I think ultimately once we engage with ethics boards to get approvals, in the US they call it IRBs, and in the Canada REBs, research ethics boards, and I think they sometimes prove to be less resistant than we anticipated them to be. So if you go over there, engage with them, and really justify downloading and working on not just tens or hundreds or even thousands of images, they might be more open than we thought they would be. The other thing is, because of this very problem of data sharing across centers, people have suggested federated learning. But it sounds easier than when you actually want to do it, because if you want to do federated learning, meaning you don't get the data, you send your algorithm there, and then it trains on their data. But ultimately, it's a tough thing too. It hasn't really taken off because you need to use the same platforms because they need to be able to execute your code. They need to have their data organized in a consistent way. So even though people have been talking about it, I really don't know how successful federated learning will be.
Okay, we
Yeah,
had,
I don't
I
have
think,
anything.
oh, sorry. I
Nothing
think,
to add. I don't have anything to add.
okay. I think those were great responses though. Good question though. Um, so I think if you guys have time, we have one more question in the chat that we can ask quickly. But if I know if some people it might be 5 o'clock somewhere for some people. If you have to go, that's okay. But Connor Smith asked regarding something that Raman had
Yeah.
kind of looked at earlier was so if we're using LLMs, using clinical charts, if we're using something like ChatGPT as the basis of that LLM, how do we weigh the risk of an LLM hallucination
Yeah.
when we're using that to guide a clinical decision?
And that's a great question by Connor. And hallucinations, not just from language models, but also from vision models, are a big problem. And so I think that's why we badly need metrics and again, physician at the center of things to really rule out these things as they're happening. So the big problem is how do you even detect hallucinations as they come in? So we need that, and there's a little bit of publication here and there emerging on metrics for to quantify hallucinations. Um, but it's not my area of deep investigation, but I just know that there's metrics emerging, and we really need, and we're proposing our own works to have clinicians look at these things and really quantify and describe and explain when they see these things. Um, but it's a very tough problem, actually. Yeah, generative AI, I would say that's one of the biggest, kind of like in the world of denoising, AI-based denoising. Sometimes you get images that look very nice and smooth, but then they're actually sort of decreasing or not improving ability to detect tumors. They just give you more pretty images. Here it's even worse because you might actually get extra tumors and you might get like weird things that emerge. And so yeah, it's definitely a research frontier.
Yeah,
And
besides the hallucination, there's also like an out-of-date knowledge problem. That's also notorious. Like all these can, yeah, fall into category of model errors or uncertainty. So we need to deal with them like, yeah, building a human-in-the-loop system and a better interface for for us to report and record them. So that's my opinion.
I don't have anything to add here.
Okay.
okay,
So yeah, I guess if there are no other questions from the group, I just wanted to, I mean, I think collectively, everyone who might have left already, but even people who are still here, I think we wanted to thank our speakers. Really appreciate it. This was super interesting. I wish I could talk to you guys all more about the work that you do because I'm doing stuff like this and super interesting, I think, to collaborate on this kind of stuff. So really, thank you so much. And again, I hope that whoever is still here, students wise, I hope that we get to see you guys in London at the annual scientific meeting. And yeah, keep kind of C3 on your tab for future sessions like this. So thank you all again, and yeah, see you next time.
thank you.